Welcome and thank you for joining us. This is the Snapshot Session 3 on Person-Centered Care. My name is Robin, and I'm the moderator for the session. So before I introduce our speakers, just a couple of reminders. You can increase the size of the slide presentation by right-clicking on the presentation image, selecting Picture in Picture, and resizing the pop-out window. This is a snapshot session, meaning we have two presentations, both on the theme of person-centered care. After the first presentation, I will take just a minute or two to answer any questions that have come up in the chat. So if you have anything that you'd like to see discussed, please pop it into the chat during the presentation. And so the presenters don't have to worry about the chat. I'll be monitoring it. After both presentations, we'll have a discussion period with all the presenters. So at that time, you'll be able to ask questions using your microphone. So once we're done, I'll get you to raise your hands and so that I can I can call your name, and then you can unmute yourself at that point. So now I'll introduce our first speakers. Our first presenters are Katie Dunham and Kristin Kerr. Katie is a primary care nurse practitioner with a background in emergency nursing, primary care, rapid access addiction medicine, and withdrawal management in a community-based live-in setting. She is currently the nurse practitioner lead for Stonehenge Therapeutic Community, providing virtual RAAM services through the digital front door platform in Ontario. She also acts as the nurse educator for Medify, an Ontario-based organization that provides mentoring, education, and clinical tools to those working in the field of addictions. Kristin is a registered social worker and experienced leader with over 15 years within the mental health and addiction sector, working with people of all ages. As the Chief Executive Officer at Stonehenge Therapeutic Community, Kristin strives to create communities where people living with substance use are welcomed, supported, and thriving. She embraces the opportunity to drive health system change forward and bring health equity to vulnerable populations across her community. Kristin believes that organizational health drives the quality of care to clients, and she takes pride in developing strong organizational culture and staff engagement. So Katie Dunham and Kristin Kerr will be presenting on increasing accessibility to RAAM services, and take it away.
Thank you so much, Robin. Thanks everyone for being here. We were just talking about how many hot topics there are that are going on right now. So thanks for joining. We're really excited to take you through our clinic and really just brag about what it is that we do. So hopefully you can adapt some of it if you don't do it already. And we want to hear if you're already doing some of these things too. Hopefully I can click through. There we go. Okay, so of course, disclosures of financial support first. So the program hasn't received any financial support or support in any kind, but I received payment from Stonehenge and Medify as an employee of both organizations and honorarium from Indivir for various speaking engagements. And Kristin has received payment from Stonehenge as an employee. Okay, same personal disclosures for myself and for Kristin. Mitigating potential bias. There really shouldn't be any bias in this. We're not likely to talk about specific brand or generics, but if they pop up, we'll try to use both and avoid that. I don't think I'm talking about Medify products in this conversation, but we're definitely talking about Stonehenge, so heads up for that. So the title of the presentation is Innovations, but really we're talking about how Stonehenge maximizes different. And we do that through a focus on format and location, through being an NP-led addiction medicine team, and through so much peer support that we have, we've ensured maximum accessibility of our RAAM clinic network. And the next number of slides are really going to focus in on what those three topics mean and how we've taken what other clinics probably do have at this point, peers, virtual services, and NPs, but we've taken them to the lengths to make our program as great as possible.
Hey, thanks. Hello, everyone. Thank you for joining us. I'm going to take us down a little bit of a walk down memory lane so we can know sort of how Stonehenge has landed in the place that we are now. We are proud to say that the half-day clinic that opened in Guelph in 2017 was the first clinic to open outside of the initial Medify pilot project. And we, at that time, opened without any funding. It was a collaboration of a variety of community partners and Dr. Yelena Chorney, who some of you may know, who led the addiction medicine component for us to be able to open that clinic and begin some proof of concept outside of Medify in different parts of the community. And really what we're talking about here through this slide and the next is about format and location. You know, we live in our area that we serve is Guelph and Wellington. So we have an urban center and a large rural area. And what we have come to notice since 2017 is that there were a variety of ways we needed to expand our format and our location to make sure that we were maximizing the accessibility for people, especially within the rural areas. So what you can see over each of these years, as we did eventually receive some funding, which was very helpful, is that we have intentionally built bricks and mortar clinics. So where people are coming in person to see us, both in the urban and rural areas. We've expanded the format through the types of staff that are present within the clinics. So including the NP team in 2021, which Katie will talk more about later. We got a mobile van, so a van that is able to meet people where they're at, go to where there are areas of challenge or need, and provide these services there. And then most recently, the digital front door, which we launched this year, which I'll talk about a little bit more in a minute. I think what's important to recognize here is that Stonehenge has been really committed to enhancing the availability of addiction medicine services in our area, because without these clinics, there aren't many other options, especially so easily accessible to people who are in the community and not in an inpatient setting. And so that's why the accessibility has been such a focus for us through format and location, to make sure that people are able to access this, because otherwise they wouldn't be able to. Okay, next slide, please. Thanks, Katie. So what you can see here is the current state of our clinics, and how many people we serve. So if you look, our bricks and mortar clinics are offering 48 hours of walk-in weekly. The mobile clinic, which is the van, is currently 15 hours weekly, and then the digital front door is 30. One of the things I want to note particularly about the digital front door is that it offers consistent hours. It's 5 days a week. It's the same hours every day. So for people who are experiencing some level of chaos in other areas of their life, there's a predictable, accessible option here. For those of you who don't know what the digital front door is, it's a fully virtual RAAM clinic. So Katie is the nurse practitioner who facilitates that primarily for us. So people can, through their phone, through their tablet, their computer, they click on a link and they are brought into a waiting room. And then from there, the practitioners in the clinic come to them. And they're able to get the full suite of services available through the in-person RAAMs, but fully virtually. And so that's available 5 days a week. And we'll talk a little bit more later about that. We've had really significant uptake. We offer that, and the Royal is the lead proponent. The Royal Hospital in Ottawa is the lead proponent for that. And we're pleased to partner with the Royal, among other partners in the province, to support that. So our clinics are staffed by a variety of folks, many of whom you can see here in this photo. But we have medical office assistants, peer support workers, counselors, and NPs. And it's the makeup of this clinic that really also helps to improve that accessibility. One other thing I just want to add before I throw it to Katie, in relation to format and location, is that we do also have a toll-free number that people can call at any time and leave a message. But that's another way that they are able to get in and access service, get immediate assessment to see what their needs are, and make sure they're getting referred to the best place to access service and not showing up where they don't need to be. So format and location, key option for us. Over to you, Katie.
Thank you so much. So now I get to brag about nurse practitioners, which, if you know me at all, it's one of my favorite topics. I'm happy to do. So what you're seeing on the slide are pictures of the nurse practitioner. So we are a fully nurse practitioner-led team, 7 nurse practitioners in total, and growing with more nursing, hopefully in the future. And because we have the beauty of the virtual clinic option, we also have the luxury of having providers in totally different locations across Ontario. That's amazing, but does lead to some restrictions in terms of us getting to know each other. So we were very lucky that Stonehenge let us have a nurse practitioner retreat. So these are photos from our NP retreat. I love kayaking, but I swear I didn't choose it. The team did. And we went kayaking for an entire day. We connected. Some of us met for the first time in person, face to face, and we shared our interests and our work interests and what we like doing and what we like focusing on and what our values are. And it was really significant for us to be able to do that and to bond as a team, because we do try to work so collaboratively. We're very fortunate that Stonehenge lets us run in whatever direction we want to or have interest in. So we have nurse practitioners that focus more on the psychosocial, some that like procedural skills. We have a nurse practitioner that's running Stonehenge's Safer Supply program. We have NPs that work in withdrawal management specifically, and some that split their time between withdrawal management and the RAAM clinic, some in person and some virtually. So with all of those options, any person, any provider can find what they like doing, and they can run with what they like doing and find their comfort. But it also means that the patient gets the care that they need from Stonehenge as an organization. So if we have someone that might benefit from another provider more, we can talk to them, or we can transfer the patient. And it's not even transferring them because it's all within the same service. So it was fantastic to get us all together to be able to share how we can work more collaboratively, which isn't always easy, but we're really happy to do it because it benefits the team so much. So there's that benefit absolutely for our work. I think one of the things people don't like to talk about a lot is the finances and the politics behind different professions. And in our presentation of maximizing different, nurse practitioners are different, and that we are not fee-for-service based. And sometimes that sucks. And sometimes we wish that we had that ability. But in taking that and trying to make it the most positive thing that we can, it means that we're salaried employees. And if you have the right employer, that works out pretty darn beautifully. So we have the luxury, unlike someone that's sometimes stuck with a fee-for-service model where they really have to think about how many clients they're seeing, because that's income that keeps the lights on, that keeps more clients being able to be seen. We don't have to think about that. I honestly couldn't tell you how long my intake is. It takes as long as it takes. If the person is in crisis, they get more time. If they're pretty breezy, they get less time. And it just runs that way, which is really great for patient-centered care. So we do have the luxury of that happening. It also takes away this idea of any kind of hierarchy in the system. We're all on the same page. And that's not just because we're all nurse practitioners, because I do hope that we expand and have more RPNs and nursing and other staff that are involved in it. But it's a lot because Stonehenge has allowed us to work to our full scope. Whatever capability we can find best practice for and practice in the best way, we're able to do that. And for any profession to feel they have purpose and meaning and they're really practicing autonomously, I think that's a requirement. So I think the more team members that we brought on, we would absolutely encourage them to work to their full scope so they would feel an absolute part of the collaborative team, which would be amazing. I think the other, sorry, go ahead. Yeah, please.
I was just going to say, for those of you who are administrators on the line, we, as you saw from that timeline before, we only have had this nurse practitioner team begin in 2021. We now experience a stability in this program area that we could not find before. We had this NP team. And we also, because they're employees of our organization, they are a part of all of our team activities, our performance evaluations. They're integrated into our team culture. They're an employee as everyone else, as to Katie's point around there not being a difference or hierarchy in the team. Mm-hmm. So from an organizational perspective, it has brought a stability and a fulsomeness to the clinics that we hadn't found before.
Yeah. And I think Kristin was sharing that perspective with me earlier. And I think from that, reflecting on it, it makes the NPs like the organization more too, which makes us work harder for the organization. Honestly, I've been a contract worker. I've done tons of contract work for years, and it can be wonderful. And you can work for the same organization or the same system or the same provider for a really long period of time, but there's always something that's a little bit, you're on the outside of it. Why would you put more effort in when your hours are being paid for this and that's it? And not just for the NPs, but I think everyone that's an employee of Stonehenge really gets involved in the culture because it's so positive. There's fall fun days. There's baseball days. We had a day to go and play baseball as a whole team with clients. It was so amazing. And I think being an employee in a system that's so supportive is amazing, but unique, and it shouldn't be. So I guess that's kind of my messaging for this one is there are definitely NPs that struggle to find that they're able to work to full scope or have real autonomy in their practice. And it's possible. there are employers out there that will let that happen. So for the employers, try to make it happen, talk to your NPs, and for the NPs, find an employer that you feel like you can just run with your practice because it's such a lifting feeling. I could go on, but I'm supposed to move on. So I'm going to go to the next one. So, but I get to brag more because this is right up there with the NPs for me is our peer support workers. So this isn't unique. I'm sure many of you have peer support workers at this time, but I've been told that Stonehenge was the first RAAM to have a peer support worker. Is that right, Kristin?
That's correct.
Which is so amazing. And now we have so many peer support workers. And I come from a background in addictions where I didn't even know this was a thing. I didn't know that peer support working was a role that could happen. And now to work with the peers that we have is so beautiful to watch. We have peers that work in all of the in-person or brick and mortar clinics throughout the week. We have 4 peers that work in different areas. So we have a lot of rural space. So we have peers that will meet the clients in those locations. We have a lot of urban space. So we have clients that work downtown and they work in the community partnerships that we have, like in housing support, where people need to find where they're going to live. So having our team members and the team members with the most experience about what our clients have gone through, having them in the community to make these connections means everything to make sure that someone feels welcome, non-stigmatized, and they know that we're an option. Word of mouth, as we all know in this field, is so important. But my favorite part is definitely that we have 3 peers that work in 3 different hospitals, 5 days of the week. And it's so incredible to make an actual seamless connection from the hospital to a community provider. And this is absolutely, and Kristin will speak to this, I'm sure, about partnerships. And I know you've heard it throughout the conference, I'm sure, so far about how important partnerships are. But this has been amazing. So before, if you're in the hospital, it's an easy checkbox to say, oh, referred to addictions provider. And then the addictions part of that person's presentation is done and you can wash your hands of it. That checkbox is still possible, but when you check that box, you have a Stonehenge peer worker coming to greet you in the emergency department upon discharge or in your hospital bed, and they can tell you about our services. But even more than that, they now have tablets or iPads or whatever it is, and they pull them out and put them on the digital front door where they actually greet our team and make real connections with counselors and with the nurse practitioners. And they can either just do a meet and greet or they can actually begin service with us before they've left the hospital. So we're no longer a concept to that patient of, oh, there's a clinic the hospital told me I could follow up with. They know us, they have that connection, and they know how to reach out to us again if they want to. I couldn't speak highly enough about it, and I would encourage all hospital RAAMs out there that exist to come up with some kind of partnership like that because it's such beautiful access. From the peers themselves, I was very lucky that I got a couple of them to give me some quotes. So one thing about the peer team or role that's my favorite is the connection we are able to offer others through our lived experience offers a sense of hope for others and reminds us of that hope for ourselves as well. And that's Evelina, one of our peers. Another is peer work is an opportunity for us to use our lived experience in a way that is valued and celebrated. as a peer, I never have to hide behind my past or hide my past, sorry, where in other roles or settings, that past is stigmatized at best and criminalized at worst. And that's Jason, one of our other peers, which is really powerful in itself. Kristin, I'll pass back to you.
Yeah. So, I mean, we've just spent the last 10 or so minutes telling you all about the things we think we do that are really awesome. But I think really why that matters is because the clients are getting the support that they need. And you can see from our charts here that over the months, the numbers of individuals that are accessing our services are increasing. You can also see the difference for the digital front door in terms of how many more people are able to access that service. One, because it's 5 days a week and our in-person clinics are usually only 2, maybe 3. But also because of the accessibility, as Katie's just said, they're coming to us from all sorts of places. But I think you can see here from the stats and the quotes from clients, really, they are getting the service they need. It is a stigma-free place where they can come to talk about their substance use and what they'd like to do different or not. And both of those things are okay. They are getting support from a variety of folks. As Katie's mentioned, they're getting support from peers, which is irreplaceable. I just want to echo what she has said. I have seen incredible things happen with peer support workers that couldn't happen with other folks providing that support. Incredible. And all the way through the counselor, through the MOA's initial engagement with them, through the NP. So clients are getting what they need. They're getting stigma-free service. And the reason that we have focused so much on format and location, the NP addiction-led medicine, and peer support is to make sure that staff are getting, the clients are able to get what they need when they need it. So thanks so much. Katie, back to you.
Thanks. Yeah, I don't know if people can see our quotes that are on there. I like the client quotes, so I'm just going to read them out quickly. That one is, I never had any sense of direction. I always defaulted to drugs, and the RAAM has provided me with ways to get better and get healthier. Oh, sorry, can you hear me okay?
Yep, you're good.
Sorry. Another is, this is the longest period of sobriety I have had in over a decade, from one of the clients. And 95% of RAAM clients reported receiving easy to understand information about how to manage their health concerns. And that's the virtual program. I also thought a fun thing that kind of got added in yesterday's presentation. Thank you for the presenters for the virtual talk. They mentioned, I hope I'm not quoting this wrong, that they saw a 20%, I believe, increase in their service access with the virtual platform. And just quickly looking at it, it looks like we have the same in our numbers in terms of who's able to access us in person and the great expanse of clients that are able to access us virtually, which those are clients that wouldn't have been accessing service potentially otherwise. So again, very grateful that we have all of these different ways of reaching the people where they are. But I could go on, so I'm going to stop for real this time. we'll wrap it up. Sorry, thanks, Kristin. We have our information. We're happy to share anything else that you need along the way. Thank you so much for being here, and we'll pass it back to Robin.
Thank you. So Angie asked if there were any fully virtual RAAMs in Toronto or elsewhere, and I don't know if anybody knows of any, but that kind of raised for me the question of whether the combination of the in-person clinic with the virtual access is kind of critical. Otherwise, why don't you just give us all access to your RAAM virtual so that we don't have to worry about it anymore?
So, well, I mean, that I will say there are a variety. Sorry, Robin, confirming you're looking for us to answer that question.
Yes,
right?
yes, yeah.
Okay. I just didn't want to take up time for Laurence. I think there are a variety of digital front door clinics out there that are working in partnership with the Royal, and I think they are always looking for ways to expand that network across the province, but also across the country. They're doing some really amazing work on that front. We were very lucky to get in the early days in relation to that. I think certainly folks are able to access our clinic, and it is still a limited resource. There's only so many people that Katie can see in one day. But it is a thing that we are continually looking to grow and enhance. as for this reason, Robin, and that the Royal is looking to grow and enhance so that people can get access to this service wherever they are in the province.
Okay, great. Well, thanks a lot, Katie and Kristin. Yeah, oh, sorry, did you want to add something, Kate?
Yeah, just to add, sorry, that I really do think I love the virtual option. I can't say that enough, but it is not a replacement, in my mind, for in-person care. There is a connection that happens in person that can't be matched virtually, and there's certain services that are provided in person. And I think that's where Stonehenge is doing it right, in that we try to offer every type of service that's available, not just the one. We were just speaking about the digital front door because it's new and fun and very exciting. But absolutely, it needs to be a blended model. It can't just work as a standalone. For me.
Okay, thanks, Katie and Kristin. We're going to move on to our second presenter. So Laurence Batmazian is a family physician. He received his medical degree from McMaster University and completed his residency in family medicine at St. Michael's Hospital in Toronto. After residency, he worked as a hospitalist in several community hospitals in Southern Ontario, while also running a small mental health counseling practice with an interest in personality disorders. He completed a JD at the University of Michigan and is a licensed attorney in New York State. Dr. Batmazian is now working to review the professionalism curriculum at the Schulich School of Medicine. He has a published article in Canadian Family Physician looking at how recent Supreme Court decisions will affect professional regulation. He is excited to present on the intersection between addictions, medicine, and criminal law as it paradigms how the legal world affects medical practice. Welcome, Laurence. And where did I put the title of your presentation? I seem to have lost it, but you can tell us what it is, because I...
Sure. Sounds good. Sound check works. Excellent. Great. I'm just going to share my screen. And okay. I trust that my screen is there, but feel free to jump in, Robin. Okay. So, all right. So I'm going to present today on a review of Canadian legislative initiatives to address substance use. Before I start, I just want to thank Medify for supporting this presentation and allowing me to present today, and my dear colleague, Dr. Ahmed, who encouraged me to bring this forward. It's always a big honor to present to peers and colleagues. So starting off with disclosures, I do receive some money through employment with the United States government. So I'm required to read this statement that the views and opinions herein are those of the author and not necessarily represent the views of the United States government or its components. And I also work for the Schulich School of Medicine on their professionalism curriculum. I also have to provide a disclaimer that this is a compilation of legislative updates and should not be interpreted to represent legal advice. So if you get arrested, please do not call me. And of course, it's not create a lawyer-client relationship. All right, so let's just talk about the objectives. So as the title suggests, I'm hoping to chat about some of the legislative initiatives that have come across Canada throughout the last 2 years, both from the federal and provincial levels for managing addictions and substance use. The way that I put this together is that I basically looked at all of the proposed and passed legislation across the country over the last 2 years. Any bills that related to addiction and substance use we're going to cover in today's presentation. I specifically excluded budget bills, mainly because I didn't want this presentation to become a laundry list of various initiatives that have been funded, and instead focus a little bit more on some of the legislative advances. So to set the stage, the reason drugs, the drugs that we talk about at the PHI Conference are generally legal across the country is because of the Controlled Drugs and Substances Act. The purpose of this act, as stated, is the protection of health and public safety. The purpose of an act is important, which we'll discuss in a few slides. The Constitution Act of 1867 decides what things fall under federal legislative authority and what things fall under the province to regulate. And criminal law is a federal responsibility in this country. And so the Controlled Drugs and Substances Act, at its core, is a criminal statute. Specifically, it says that it says that possessing a Schedule 1 through 3 drug is a crime. That's how the federal government regulates drugs. They have said that if you double doctor, which means to go to different healthcare professionals and not tell a previous one that you've been prescribed something, that is a crime. Same with trafficking, same with importing and exporting drugs. Under the Act, there's different schedules. Okay, so Schedule 1 includes opiates, cocaines, and amphetamines. Schedule 2 is synthetic cannabinoids. 3 is methylphenidate and psilocybin. And Schedule 4 is benzodiazepines, barbiturates, and steroids. The schedule is, as far as I can tell, a policy decision by the government on how dangerous they view the drug to be, and the level with which they want to provide deterrence for people to possess, traffic, or import them. Because the punishment that you get as a result of breaking the Controlled Drugs and Substances Act depends in part as to what schedule the drug that you were possessing is in. So with that background, let's talk a little bit about what's going on across the country. So federally, they are working on removing the mandatory, or federally, I shouldn't say they're working on, they did in 2022 remove some of the mandatory minimum penalties under the Controlled Drugs and Substances Act, and they created diversion principles and mechanisms. So let's talk a little bit more in detail about both of these. So the first is that all Drug and Substance Act offenses that had a minimum mandatory penalty have had that minimum mandatory penalty removed. So I'll give an example. So R.V. Lloyd was a Supreme Court case from around 2016. So the Harper government in 2007 created many of the minimum mandatory penalties in the Act. And what has happened since 2007 is that the Canadian courts have started to knock down those mandatory penalties as a violation of the Charter rights. To be clear, the Canadian courts, as a general rule, seem to really be quite against mandatory minimums. And so the Trudeau government has said that has removed them. And they've championed this, but to some extent, many of the mandatory minimums were on their way out as constitutional violations. But so for R versus Lloyd, kind of an interesting case. So this gentleman was in Vancouver. He had been convicted of trafficking, been released, and then a month later was recharged with trafficking, and he said to the court during his sentencing that he has an addiction problem and that he was trafficking drugs in order to continue to feed his addiction, and was interested in seeking treatment, and that the mandatory minimum was a violation of his ability to seek treatment and to move on. He received the mandatory minimum of 12 months imprisonment for his second violation of trafficking laws. And he actually appealed the sentence to the BC Court of Appeals, which actually increased his sentence. They felt that 12 months was too low, and actually resentenced him to 18 months in prison. And he, of course, appealed this, and the Canadian Supreme Court actually took this case on. And he argued that it was a violation of his charter right to not be subject to cruel and unusual punishment, and that the punishment was grossly disproportionate for the crime. One of the things that you can do in Canada, which many countries actually do not allow, is that you can challenge that the punishment is disproportional, not to you, but to a hypothetical person. So Lloyd actually presented the idea that if you were arrested for sharing marijuana with your friends 9 years ago, and you were convicted for that and served no jail time, and then 9 years later, you were sharing marijuana with a friend and once again was reconvicted, you would actually be subject to a year of imprisonment. And the Supreme Court in a 9-0 case actually felt that 12 months imprisonment for that was grossly disproportionate. And the words they use is that it would shock the minds of the average Canadian that someone would be sentenced to that high sentence for that crime. And so as a result, they knocked down that minimum mandatory penalty, and sort of left the door open for others to be knocked down for similar reasons. So the Canadian government at the federal level has decided let's just get away from this completely, and just removed all minimum mandatory penalties. So that's actually a big deal for a lot of people. The other thing that they created was diversion principles. So the Trudeau government in their opioid epidemic plan talked a lot about bringing evidence-based practices into the criminal justice system. So the Controlled Drugs and Substances Act, in fact, contains diversion principles now. And they bring up things such as substance use should be addressed primarily as a health issue, that intervention should be evidence-based, that criminal sanctions can be stigmatizing, interventions should address the root cause as opposed to the after effects, and that really we should be expending our judicial resources towards things, towards leaders of organized crime groups, as opposed to the people who are suffering at the bottom. So they've created diversion mechanisms. So the bill now, or the legislation now, requires officers and prosecutors to consider whether, for people that are charged with simple possession, whether it may be better to just not charge them, or whether to give them a warning, or whether to refer them to a program as opposed to taking them through the criminal justice system. It also creates a registration system for these warnings and referrals. That way the government can track them. Now, nobody who's charged with simple possession can say, well, the officer and prosecutor didn't consider the diversion principles. The law is clear that if a prosecutor chooses to charge you, they choose to charge you. But at the very least, they are instructed, and the prosecution manual has been updated to require them to consider whether criminal justice system is the best choice for that person. The other thing is that they have explicitly protected healthcare workers. So it's always been included in the common law, which is sort of the unwritten law that, if a patient, leaves their meth in your clinic accidentally, you ought not to be arrested for possessing their meth. So if you have possession and it's in the course of your duties as a healthcare worker, and you bring it to the pharmacy for lawful disposal, you're protected. So the other component of this is Section 56. So Section 56 has been around for a while. This allows Health Canada to grant exemptions to the Controlled Drug and Substance Act. So Section 4 of the Act says, look, any possession is illegal. But as you can imagine, nurses sometimes, give opioids in the course of their duties to patients. Trafficking is illegal, but physicians will occasionally prescribe controlled substances. Drug companies do produce the substances and do research with them. So those are all explicit carve-outs, and Health Canada just grants these as blanket carve-outs. So there's a blanket carve-out saying if you're a physician prescribing a controlled substance, that is not a crime, which should seem obvious, but does, of course, need to be put down in writing. Possession while at a supervised consumption site, there's now a Section 56 exemption for that. And now many of you may have heard in the news that the opposition leader has put a motion to end safe supply programs. And I'm sure many people are thinking, what's going to happen to safe consumption sites if the federal conservatives were to come in. And the answer that I would give there is that many of you are probably familiar with the Insight case, which was the first government-sanctioned safe consumption site in British Columbia in 2003. The Harper government did not renew their exemption, so they had a Section 56 exemption. And they brought that through the court system all the way to the Supreme Court. And the Supreme Court said that denying Insight's renewal of their exemption, whereby being in Insight with drugs is not a crime, and being a staff member of Insight helping clients is not a crime, they have essentially constitutionally protected that. They basically, so everyone has a charter right to their liberty interests. And they said that the federal government's choice to not renew Insight's exemption was an arbitrary and disproportionate limitation. Because they looked at the evidence and they said, look, the point of the Controlled Drug Substances Act is to advance public health and safety. And Insight has provided a ton of evidence to show that they actually push public health and safety forward. And the government was unable to really show that Insight doesn't serve the objectives of the Controlled Drugs and Substances Act. So as a result, the court said, denying their exemption is arbitrary, and essentially ordered the government to create a Section 56 carve-out for them. So I think it's safe to say that safe consumption sites are constitutionally protected in Canada, unless evidence is produced otherwise to suggest that they don't advance public health and safety. Safe supply doesn't have the same constitutional protection, likely because there isn't that same evidence, and certainly it hasn't come through the court system yet. But something to think about, because I know that there's a lot of advocates who are at this conference, and that's sort of the state of the exemption process. Now, many of you will know that British Columbia actually has a Section 56 exemption right now, where less than 2.5 grams for the purposes of personal use of opioids, cocaine, methamphetamines, and MDMA is exempted from the criminal components of the Controlled Drugs and Substances Act. There are, of course, requirements. So, for example, you cannot bring your opioids into schools. You cannot fly with them. You mustn't. It must be for your personal use. So if you're caught trafficking in opioids, even if it's less than 2.5 grams, it's certainly still a crime. You ought not to use cocaine and drive. That remains a crime. But for simple possession, walking on the street with less than 2.5 grams of opioids for yourself, not on school grounds, there is a Section 56 time-limited exemption from that, from criminal requirements. Okay. British Columbia in 2011 allowed nurse practitioners to assess patients for involuntary admission under the Mental Health Act. They passed this legislation in 2011, but did not put it in force. Under their opioid epidemic plan, they have finally put it into force as of February 2023 and are saying that this is part of expanding access to services. When I initially proposed this abstract to Medify, I was hoping that the Compassionate Intervention Act, that we would see some draft legislation for this. This is in Alberta. It has yet to be introduced. It was brought up during the election campaigns for the Alberta provincial elections. It is in the mandate letter to the minister, so my high suspicion is that this is coming, but no draft legislation has appeared. What we do have is the UCP's official answer about the act. They say that it's about making a petition to court for a treatment order when someone's a danger to themselves. The Premier's chief of staff later clarified that intervention would be forced, but treatment wouldn't be, and then added, except in certain cases. So we're not entirely sure what this is going to look like. They've said that they will model it off of Portugal. So Portugal has what's called dissuasion commissions. These commissions are made up of a legal expert, a social worker, and a health professional, but they receive support from psychologists and sociologists. Often people in the media say that Portugal decriminalized drugs. That's not entirely true. It's still a crime, but if you are caught with 10 days or less of drugs, that's the cutoff that they've arbitrarily decided, you will, instead of being criminally charged, you'll be required to see a dissuasion commission. There's one in each department of Portugal. It's a little bit easier because Portugal's a lot smaller of a country than Canada is in terms of geographical size. The Dissuasion Commission will meet with each person. They assess your reasons for drug use. They make appropriate referrals. Often they will have a forthright discussion of health risks. The commission is empowered to make what's called administrative sanctions. These are not criminal penalties, but they are sanctions that if you don't follow them, you could, extremely rare, but you could be referred to the criminal system. But in short, the sanctions are very typically things like being required to have a discussion around treatment options. You might get a written warning. There are fines available up to, I think, 100 euros, but the fine cannot be given to someone who has an addiction. Typically, the sanctions themselves are basically suspended. As long as the person seems even remotely open to treatment, there's essentially no sanction. The process is confidential. I reviewed several interviews from commissioners on the dissuasion commissions, and they often said that really there's really no penalties whatsoever. The goal is really to just work with people to try to connect them to health resources. And really the biggest thing they'll do is if someone's not ready at that time, to sort of book another appointment in some time to recheck in. Oregon, so Alberta has also looked to Oregon as to how they did it. Oregon passed a referendum in 2020. This was not a decriminalization choice either, even though that's how the media often portrays it. What they did was they created a special class of crimes called Class E misdemeanors, where possession would get you a $100 fine. And if you go to court and you say, look, I contacted a treatment center, or I contacted a place for screening for use disorder, they would dismiss your charge. Unfortunately, Measure 110 has come, the data has not been as supportive as people were hoping. So they were hoping to see, especially when they were pushing the referendum, they were hoping to see a drop in opioid use deaths and opioid use associated crimes. And they have not seen that. Unfortunately, they've seen an increase in both. And so while this was a step, I think, very possibly in the right direction, it's come under a lot of fire. Basically, the no-show rate to court after being charged with a possession offense is close to 2/3. Which is a challenge because many of those people then receive a criminal conviction. because they did not show up to court. 10% will have multiple violations, so they're probably stuck getting criminal conviction either way. So out of the 6,000 people that have been charged in the last 2 years or so under Measure 110, only 50 people have shown up in those 2 years and had their charges dismissed. The other component is that they have diverted their cannabis tax revenue towards grant funding for harm reduction. That has come under fire as there has been a lot of concerns around accountability for the finances. So that has been a challenge too. Then moving along, so the next few are bills that I just sort of discovered and have thrown in here, but none of these are going to be groundbreaking. So in Manitoba, the Addiction Services Act was proposed. It was actually proposed by a member of the government, and the goal was to improve transparency and accountability. This act is not a small deal. It would have required licensing of bed-based treatment services, supervised consumption site withdrawal management services, addiction treatment services. It was a pretty sizable regime to regulate, and so it did receive some public pushback because basically it's adding red tape to addiction management services. Now, of course, at the same time, the government has a sincere interest in transparency and accountability, but it's often quite hard to find that balance. In any case, this bill didn't even make it out of committee, so it's unlikely to continue. Ontario had a private member's bill, the Right to Timely Mental Health and Addiction Care for Children and Youth Act. The bill would direct the Minister of Health to ensure mental health or addiction services are available within a month to a person less than 26 years old. This has been introduced. It's not. There is essentially no chance that this will pass. Nova Scotia, this one's a little bit more interesting. So, so the Crosby Memorial Trust Fund was created in 2003 by legislation. It basically took a fund created by criminal fines on people who had drug or alcohol-related offenses and used that money towards building abstinence-based addiction services in the Annapolis Valley in Nova Scotia. The fund's been exhausted. Basically, they passed an act to dissolve the fund. They've used all the money, in short. This was almost certainly just a regulatory manner that had to occur. But I can't help but think, in 2003, it seemed quite logical, I think, in the 2003 mind, to take criminal fines from people with addiction and then use that to fund abstinence-based services for people with addiction. I'm not sure that in 2023 we think the same way about how fines and addiction management work. And I think that certainly, as anyone at this conference would agree, that there's more than just abstinence-based models that are worthy of funding. But anyway, kind of an interesting, I thought it was a little bit almost representative of the times to see this repealed, even though it was likely a regulatory manner. The debate in the Nova Scotia legislature on this bill, I think, lasted roughly 2 minutes. But anyway, I thought it was still representative of the changing minds. Another one was the Protection of Children from Abusing Drugs Act in 2021. This was proposed in Nova Scotia. Basically, the act said if the court thinks there's a child that's abusing drugs, they can basically grant a protection order to confine the child in a protective safe house. And that it was kind of purposefully left a little bit vague. I mean, the safe house might be with a parent or might be custodial with the government. But anyway, interestingly enough, and probably to not many people's surprise, this didn't proceed further either. All right, so and that's it. I mean, that's what has been worked on from government from a legislation perspective outside of the budget realm over the last 2 years across Canada and the provinces. And I look forward to hearing any questions. Certainly, if anyone knows a journal that would want to publish this, feel free to let me know. And I do want to correct myself for one thing, which I said earlier on, that it was a 9-0 decision for R.V. Lloyd. Actually, that's incorrect. It was a 6-3 decision, and the Insight decision was 9-0. The court unanimously protected Insight constitutionally. Anyway, just wanted to clarify that one piece. Okay, well, thank you. And I'll defer back to you, Robin.
Okay, thanks, Laurence. I've allowed people to unmute themselves, so feel free to raise your hand if you have a question or something you want to talk about. I wondered, Laurence, about does the decision that safe consumption sites are constitutionally protected mean that if you want to open up a new one and the federal government or the prevent won't grant you the exemption, that you have grounds to say, or is it only the existing ones that are protected?
Okay, yeah, that's a really great question. I appreciate that. What it really lays out is a lovely framework on how to prove that your consumption site ought to be constitutionally protected. So basically, Insight was able to show that they advanced public safety. They had reduced rates of substance use. They were able to show, from an evidence-based perspective, that there was no increased crimes in their region, and the government basically had no true evidence to show that Insight was a problem. So I think, right, if you were to lay out the exact same argument again, you'd probably have a pretty good, you have a very, very nice precedent standing behind you on how to advance the creation of your clinic. As you know, the government has created actually a really lovely, slightly convoluted process by which to get your consumption site approved. But certainly now you know that you can actually, apply to the court and say, look, not approving this consumption site is a Section 7 violation for the people in this area. There have also been subsequent cases, Robin. Sorry, your question was short, but I'll answer a little bit more here. There's also been subsequent cases, right? So looking at, the extent to which access to healthcare is a right. And that has all occurred in the interim. So you can probably bolster your argument a little bit more. Section 7 is an area of much advancement in Canada because it was originally written. Part of it was originally written actually to protect abortion rights, and the court has actually expanded it well beyond just abortion rights. So anyway, quite an interesting area of legislation. Thanks.
Thanks, Laurence. Katie, I think you had something you wanted to raise.
I did, yeah. Questions for you, Laurence. I thought that was so fantastic. And I don't know about a journal, but I do know about a newsletter that would probably be happy to host some of your information, because I think it's you did a great job of keeping all of the facts there and doing it unbiased. But I'm actually curious, since we have you here, about your personal opinion about some of them. For me, the highlight is Portugal, and Oregon was really fascinating too. So what's your take on the pros and cons of Portugal and why Oregon didn't work the way we thought it would?
Gosh, that is such a tough one. Like, why was Portugal successful and Oregon not? To be honest with you, I think a big part of it is probably the connection to services. So, uh-oh, have I cut out or I'm still here?
Oh, you're still there. Your camera isn't working properly, but we can hear you.
Weird. Okay. Anyway, sorry. So I think probably it's about connecting to services, right? I mean, so Oregon doesn't have like as clear a system as Portugal does with getting people connected to substance use services, and that I think is probably the problem. I think it's an implementation issue in Oregon, and so my suspicion, right, is if Alberta does it, at least Alberta has universal health care, so I think they'd probably be able to roll it out in a closer model to Portugal. But it's sad to see Oregon take a big step and take really a big experiment, and to see it kind of fall a little, frankly, flat in its face, such that people are saying, well, let's just recriminalize drugs then, because at least that was better. And I don't know if that's true, right? Like, I think it might be a bit confounded.
Yeah, I think that I just put in the chat, one of the things that Portugal did was it took a whole lot of money from policing and jails and so on and moved it. And not just, as you said earlier, some of it went to treatment programs, but it also went to housing, to employment, so that it didn't matter what the individual's substance use related goals were. There were options for them to make their lives better. And in the process, which meant that a very high proportion of the people, at least initially, were willing to engage with the process, right? I think so. At least that's my impression of it. I
think so. Part of the issue too is that Oregon was supposed to divert their cannabis tax fund towards things like housing, and just getting the money out of that has been really tough. Like, it's just not easy to build programs in the span of like 2 years and just be like, wow, magically success. Katie, as you brought up in your talk, right? Like, building programs actually takes a fair amount of elbow grease, and a little bit of experimenting and seeing what's working and sharing with best practices. And the sad reality is that doesn't occur overnight. Like, it's not magical, as you showed. So it's tough, but it's just sad to see it kind of be stuck,
Is there anybody else who wants to add a question or a comment? I don't see any hands up. And in the absence of them, I will make a comment related to what Laurence just said. So I used to analyze the Toronto Central LHIN's audited financial statements every year to see what the distribution of health funds were in the Toronto area. And here are the numbers. 89.5% of their money went to hospitals, 2.7% of their money went to mental health, and 0.8% of their money went to addiction services. And if we want to understand why, if we make changes, we may not be able to respond effectively enough at Stonehenge, at St. Mike's, and all across our range of services, that tells you the answer, because our services are so small relative to the rest of the healthcare system that there are wait lists everywhere, capacities are extremely limited. And, you know, if you do the math, mental health and addiction combined, the full funding for it is equivalent to basically 1 year of a typical hospital-based budget increase. So if you're worth 90%, you get a 4% increase, that's 3.6%, which is more than addiction and mental health put together. And so we have to stop looking at base budget increases as a percentage of existing and look at what is the level of funding that we need to actually have a robust system that can respond effectively to people. Because I think programs like Katie's and Kristin's, what they've done is a situation where you've got a significant input of resources to be able to create a new model that can effectively respond, rather than just trying to build small incremental improvements on the existing. So that's my campaigning moment. So I want to thank Katie and Kristin and Laurence for really great presentations, and our folks for being here. Just a reminder, the session feedback survey is in the chat, so if you could do that before you go, that would be wonderful. And a reminder that the networking sessions are coming up in 3 minutes, so please head over to one of those. I know Katie's got an NP group going, and we've got a discussion on residential bed-based treatment programs as well. So thanks again, everybody, and we'll talk to you soon.
Thanks, everyone. See you soon.
Everybody. Bye-bye. Have a great day.